Your Excellency, the President of the Federal Republic of Nigeria, here represented by the Honorable Minister of Health, Dr. Sage Ehanire. Your Excellency, our father, the former head of state, General Yakubu Gowon, DCFR, who is not only a former head of state, but a great champion of malaria and the prayer warrior of this nation, who is the chairman of today's occasion. Very distinguished delegates to this conference. I would not want to recognize everybody because I've been strictly warned to keep away from the protocol and neither standing on the protocol, but I want to proudly respect it. First, I wish to express my appreciation to the President and executive members of the Nigerian Medical Association for the honor to address this gathering. I'm thankful and humbled by this special courtesy extended to me. I need to also commend the Nigerian Medical Association for its drive and passion to improve medical practice in the country for better patient care and health outcomes, as well as canvassing for standard operative environment for its members and other healthcare providers in line with global best practices. Over the years, the NMA has continued to impress with its robust advocacy, training, and development of its members, as well as engaging in corporate social responsibility through public enlightenment programs, especially with regards to communicable diseases. The vision of this National Health Summit is one that has the potential to shape and influence the national conversation on health system in Nigeria and serve as a catalyst for healthcare reform in our country. Whilst we have made little progress in the areas of increased budgetary provision for health, development of health infrastructure, improved life expectancy at birth, and training of healthcare professionals, the Nigerian health system is still far from what it should ordinarily be. It is currently a potpourri of problems such as inaccessibility to quality health care, inadequate health infrastructure, underfunding, dearth of skilled manpower, and still relatively high infant and maternal mortality rates. These are compounded by the absence of non-functional surveillance systems, the menace of fake drugs, poor sanitation and hygiene, as well as environmental degradation. In most cases, individuals and households are made to bear the brunt of a dysfunctional and inequitable health system, devoid of any social protection. They are compelled to either seek alternative healthcare services that may be unsafe or injurious, or pay out of pocket for healthcare services that are often beyond the reach of the common Nigerian. Patient-centered care, PCC, the theme of this summit, addresses a very vital aspect of healthcare management that is critical to delivering quality healthcare in Nigeria and ensuring the best possible outcomes and experiences for patients, carers, and families. I'll begin this discourse with an overview of the PCC model as a core strategy for improving the quality of healthcare in Nigeria. Next, I will examine the conditions that are germane to successful operation of patient-centered care in our health system. This will be followed with a brief examination of the current state of patient-centered care in Nigeria, after which I'll present a short case study that supports the concept of patient-centered care as a viable option to better health outcomes and patient satisfaction. Overview of patient-centered care as a primary approach to healthcare. Patient-centered care is a practice of caring for patients and their families in ways that are engaging, meaningful, and valuable to the individual patient. According to the Institute of Medicine, patient-centered care is providing care that is respectful of and responsive to individual patient preferences, needs, and values, ensuring that patient values guide all clinical decisions. The PICA Institute defines it as an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients, and families. Whatever the definition, the patient-centered care focuses on the patient's satisfaction and their perception of good quality as indicators of quality healthcare. The PCC model acknowledges that patients should actively participate in health-related decisions in a manner that inspires trust and confidence in the healthcare system. With enhanced patient satisfaction at its core, this approach to healthcare delivery is predicated on the premise that the family plays a vital role in ensuring the health and well-being of patients of all ages. According to the Australian Commission on Safety and Quality in Healthcare, person-centered care offers important potential to improve the value delivered by health services by achieving better outcomes at lower overall cost to health systems and the community. Globally, the PCC model is emerging as a key dimension to providing quality health care. Hence, enhancing the patient experiences and delivering patient-centered care is on the agenda of virtually every country today. With increasing knowledge and awareness amongst populations in developed countries, PCC is gaining grounds as a model of preferred care. It has taken center stage in discussions on quality healthcare as it promotes flexibility in healthcare provision and creates partnerships that are beneficial to the healthcare providers, patients, and their families. In a research conducted by PICA Institute and Harvard Medical School, 8 principles that drive patient-centered care were highlighted as follows. Respect for patients' preference, coordination and integration of care, information and education, physical comfort, emotional support, involvement and friends, continuity and transition, and access to care. In contrast to the more traditional medical care method, where the patient's role is passive and the patient is seen more as just a recipient of treatment, the patient-centered care model gives a voice to the patient, since the patient's role as an active partner in the treatment plan is not in doubt. Effective PCC plans, therefore, must be guided by the following. 1, aligning patients' needs and preferences to health systems' missions, plans, and values. Patients and family must have a voice in decision-making in the healthcare process and should be partners. 2, there is need for shared information and education of both patients and family. 3, care must be collaborative and coordinated as it leads to better health outcomes. 4thly, guaranteeing and driving the process of care to ensure physical comfort and emotional well-being of the patient in care delivery, and improve access to health care and disease prevention as it relates to both patients and the population, in our case, the communities that we live in. In fostering healthcare transformation, the patient-centered care model enhances the likeliness of patients adhering to treatment plans, trust in the healthcare system, and greater and better result outcomes in treatment plans. Key attributes of patient-centered care. The patient's journey in a patient-centered care model requires key attributes for achieving safe, high-quality health care while contributing to better outcomes and experiences for patients, carers, and families. 1. On information and communication. On the surface, information and communication appear to be one and the same thing, especially because they are often used interchangeably. But there is a slight difference. Information is passing across facts and figures. Communication is gaining understanding and eliciting goodwill. It is axiomatic that effective communication drives care and compassion in the patient-centered care model. It emphasizes the importance of understanding a patient's health history, the patient's goals, choices, expectations, fears, and anxieties, as well as their perception of what they consider quality health care. In addition, there must be sharing of information among the team of carers to foster cooperation, proper coordination, and synergy. Statistics indicate that 70% of litigations resulting from poor patient experiences and adverse outcomes is often due to poor communication. In such cases, patients felt they were misled, neglected in the decision-making process, and lacked proper understanding of the services provided, especially in the case of surgical procedures. Collaborative patient and family engagement. The Institute of Patient and Family-Centered Care has observed that without sustained patient-family participation on all aspects of policy, program development, and evaluation, the care system will fail to respond to the real needs and concerns of those it is intended to serve. To improve the experience of care and ensure quality and safety, the family is regarded as an equal member of the team. They are not left out in the design and implementation of the care plan. But even more importantly, family members are treated as respectable members of the team, not as visitors who cannot access certain areas of the hospital. Where this collaboration is in perfect alignment, it replaces doubt and suspicion with trust and confidence, inevitably resulting in the psychological well-being of the family, positive perceptions of the caregiver and hospital, and lower margin of system error, therefore reducing risk of conflict and litigation. Strong, well-structured teams for patient-centered care. The PCC model is a multi-dimensional and interdisciplinary approach to achieving quality healthcare outcomes at all levels of care. It uses an integrated approach to achieve quality healthcare delivery, utilizing service delivery processes where interprofessional relationships, teamwork, and what makes the patient satisfied are the motivating factors. Comprising the healthcare team is healthcare providers, the patients, and their families. The success of the team likely depends on complete unbiased information sharing in a timely fashion, clear definition of roles, commitment to stated goals, and mutual respect for each other. Monitoring and evaluations. To achieve high-quality patient-centered care, there must be organizational commitment to continuous improvement focused on measuring patient outcomes and experiences. This must be clearly articulated in the organization's mission statement, and everything must be done to ensure buy-in by workers at all levels of the healthcare industry. The current state of patient-centered care in Nigeria. Literature on implementation of patient-centered care in Nigeria is scant. While the concept has been embraced as an imperative for providing quality health care, there are relatively few resources that give us insight on its operation and management in the Nigerian context. However, there are some factors that can be used to measure the extent the Nigerian healthcare system is compliant with patient-centered care. 1, interpersonal communication. Except for a few exemptions, most of our private and nearly all public healthcare institutions in Nigeria still practice the traditional medical care method in healthcare delivery. Here, the care is disease or illness-based. Symptoms and signs from patients are compiled and differential diagnosis made. The physician then goes ahead to initiate treatment and follow-up visits where necessary. There is hardly any communication as the patient and family play passive roles in the healthcare plan and, of course, in the implementation. When it comes to patient-centered care in Nigeria, many questions are begging for answers. And I think the chairman asked a lot of questions in the course of his speech. But some other questions are here to be answered. Are we prepared as a nation and as healthcare providers to embrace this transformational approach to healthcare delivery? Is the human resource available and adequate for this system of care? How accessible and affordable is healthcare to our growing population, most of who fall below the poverty line? More so when, as a nation, we are beginning to celebrate the numbers. Nigeria, almost 200 million. Nigeria, probably in the next 20, 30 years, will be the 4th largest nation in the world. Is that what we should celebrate about, or we should be celebrating the quality of life and the quality of human beings? As long as we begin and continue to celebrate the numbers without looking at the effects in a society where we don't have enough access to healthcare and in the indices are poor, and where there are educational problems and a lot of people are uneducated, then we are actually celebrating a very dangerous situation. Today, we're talking about insecurity in the land. A lot of it is traceable to the growing population that is likely unemployed, a growing population that is likely uneducated, and they do not have access to health care. And when you take out these two things, you have actually created pressure in the family. And the family is distorted. The children are not being brought up the way they ought to be brought up. And what then happens? They create other choices for themselves. And these choices are possibly not the best that we wish for our nation today. What is the percentage of Nigerians still paying out of pocket for health care? Is the healthcare provider warm or welcoming? Do the healthcare staff inspire trust and confidence in the ability of the health establishment to deliver quality health care, leading to patient satisfaction? These are many questions that we need to ask ourselves. Anyone who has lived in Nigeria long enough and has had to visit our hospitals have at one time or the other experienced the dismissive attitude of many of our healthcare providers. Some have acquired a notoriety for being harsh and unsympathetic to those they are meant to serve. Instead of regarding them as persons that need to be treated with respect and dignity, they tend to be perceived as burdensome. Also, do our doctors create the enabling environment and time to truly interact and adequately engage the patient? Is the patient allowed to tell his or her story, let alone allowing the family to participate in caregiving? Often, suggestions and opinions of the patient or relations are considered an affront and treated with resentment by doctors and other health staff. This shortcoming on the part of the doctor and other health staff leads to the perception that the system does not really care, except where it concerns the rich and powerful. Empathy is key on the part of the professionals in the healthcare industry to ensure the best patient experiences and expectations of quality service. Waiting times in our hospitals. It is not news that the wards and outpatient departments of our health institutions, especially the public hospitals, are overcrowded, leading not only to delays in service delivery, but sometimes to nosocomial infections. It is true that our health institutions are reeling under the pressure of underfunding, inadequate manpower, shortage of equipment, and population explosions. But it is also true that some of the delays experienced by patients in our hospitals are man-made. We must, as professionals, strive to provide the best care possible despite the challenges in our healthcare system. The doctor must show exemplary character needed to build trust among healthcare providers in order to provide the best available care and relationships with patients and their families. There is currently so much loss of confidence in our healthcare system that both the rich and poor are spending hard-earned money on overseas treatments for ailments that can adequately be attended to in our national health service system. Delayed services, system errors, and poor perceptions based on stories and frustrations out there has led to increasing patient dissatisfaction with our national health system. Universal health coverage. We may not be able to rapidly improve our healthcare system and health outcomes until we are able to that a greater percentage of Nigerians can access health care without having to pay out of pocket. 15 years down the road, we have had the national health insurance at pass, and the scheme has been on for 15 years without an appreciable impact among our people. The enrollment numbers are low and limited more to the federal workforce. It is not the problem of the national health insurance scheme. It's a collective problem of all of us. It's a collective problem of both the federal government, the states, and the local governments. We need to engage in serious advocacy, education. We need to communicate with our people to ensure that they truly buy into the health insurance policy of this nation and of the various states that have begun to now, in the last few years, engage in health insurance plans for the various states. Considering the high level of unemployment and poverty in the land, my honest view is that it is truly difficult to initiate a transformation to patient-centered care model when basic access to care and affordability is a challenge. However, all hope is not lost, especially in the primary care, as the National Health Act has enabled the introduction of the Basic Healthcare Provision Fund. Here we must appreciate the previous administration that signed the law in December 2014, and also the National Assembly that struggled to pull it through. I'm happy today because I led the committee at the Senate, and Honorable Ndudi Elumelu, who is seated here, the minority leader of the House of Representatives, was the chairman of the Health Committee in the House of Rep. And Dr. Nabulele and many other persons, I want to congratulate you on your elevation as President-elect of the CMA. Himself and his colleagues played a very major role with so many other Nigerians. And I must recognize our traditional ruler, who also played a very important role when we had the dialogues all through that period. Today, the Health Act has been passed, but I must also appreciate the president, the sitting president, who has decided to give voice to the Basic Healthcare Provision Fund, that we ended up capturing it in the budget of 2019 and also in the budget of 2018. It is something that we look forward to. We have started from the minimum because that act actually says a minimum of 1%. It's for us to continue to ensure that we utilize the funds rightly at the moment, and also ensure that we engage the state governments and the local governments to counterpart that fund, and therefore increasing the pool and ensure that we use the resources in the best interest, especially for the most vulnerable in our society. I believe that thereafter, NMA and others can lead the advocacy to ensure that we have an increment in that, because the Act actually stated not less than 1%. The implication of that is it could become 2%, it could become 3%, it could increase depending on the level of advocacy. The fund, if properly used and augmented by state governments, will increase access, affordability, and functionality of our health system, particularly at primary care level. It is heartwarming that many states are now beginning to embrace universal health coverage, with likely expansion to access and functionality of our health system. In Delta State, our contributory health commission legislation was passed as early as February 2016. And since then, we have been able to start the operationality of the health insurance in January 2017. As of September 2019, we actually had a total of about 657,000 persons enrolled in the scheme. I thank God that the minister is here. I want to plead with Mr. Minister. You're doing a lot, but you may need to carry on with a lot of advocacy to my colleagues. Many persons may just start off a program because there is a need to start it. It may be because they want to access that fund that is available, that they are starting it. But I think that a clearer understanding, which we can only achieve by advocacy visit to the individual states, we actually bring out the commitments of the various chief executives of the state. And I think that is important. And in such visits, I would also advise that you urge the governors to bring the local government council chairman to such advocacy visits so that everybody is brought on board. And I believe that in so doing, we are going to upscale the number of persons who are actually involved or participants in our various health plans in the country. Because before now, all we had done is to allow the Federal Civil Service into the healthcare insurance with a few others within the organized private sector. And that's why we have actually not done well as a nation. Some other nations, even within Africa, have been doing quite well. I believe that we can, now that we have the opportunity, we can truly drive the process. And I must appreciate NMA for bringing this whole thing into the discourse. Because when we are sure that our health systems are functional, when we are sure that they are equity plans, we can now begin to drive the processes more and more. And when we are no longer paying out of pocket, The functionality of the health system is no longer going to be questionable because the health insurance on itself has to provide some level of funding that will increase the functionality of our various health institutions. And when we have such functionality improve, the likelihood is that doctors and other health staff will no longer be under intense pressures, and their services are likely going to be better. In such a process, you find that the relationship between the patient and the doctor or the patient and the nurse is going to be much warmer and much better. But when you're working under very difficult conditions and the patients don't have money to pay, and you don't have money to pay your staff, and you're expecting such doctors and nurses and other staff to be very friendly, you are not likely going to get the best of results. So we actually need to work very hard. Achieving patient-centered care, a case study. As previously stated, there is very little literature on the PCC model in Nigeria, despite overwhelming stakeholder opinion that it is good for the provision of safe, quality health care. But we can build an available literature from other clients to support the concept of PCC as a reliable medium to deliver patient satisfaction that can be measured. For an empirical case, I'll turn to the Armstrong Institute for Patient and Quality, Johns Hopkins Medicine, which surveyed responses of patients after discharge about their hospital experiences. Using data from hospital consumer assessment of healthcare providers and systems, a total of 3,000 hospitals were surveyed, and the research found several common approaches among successful companies as follows. I'm just going to give this case study for us to realize that if we're able to make an attempt to do some of those things, it may not be to the extent to which is done in this best case scenario of hospitals, but striving to do some of these things will better bring the relationship between us and our patients, and it will help us to improve the perceptions that our patients and families have about us. One, on hourly rounds. In these best case scenarios, nurses and other clinical staff members make rounds in the patient's room every hour to address pain, bathroom needs, and positioning, and to make sure that personal items are within reach. Communication and care boards in patient rooms. The boards list important information such as new and existing medications, discharge goal, tests and procedures, and how to easily contact care providers. Bedside shift report. This is quite important. I loved it when I read about it. Nurses conduct reports at shift change in the presence of the patient and family or the family rep, giving them the chance to ask questions, understand the care plan, and correct any inaccurate information. Discharge folder. On admission, patients receive a folder with a checklist of information they will need when they get home, such as the purpose of their medication and symptoms to look out for. Post-discharge phone calls. Thank God, many of our patients, many families now have phones. Nurses call patients within 2 to 3 days to check their status and answer questions about instructions and self-care. Multidisciplinary rounds, involving all members of the care team, as well as patients and family in our various rounds. Standards of performance, creating standards for all employees to follow, such as quickly responding to patients in a friendly manner and how to respond to patients' concerns and complaints. In concluding this paper, I wish to state categorically that patient-centered care remains a viable option for us to improve the healthcare delivery system in Nigeria. It has great potentials to produce much better outcomes in cost-efficient manner, reduce system errors, and increase patient satisfaction that will radically alter the current unfavorable perception of our healthcare system by majority of the public. If we want to stop the medical tourism, I think that we need to begin to look very closely at our relationship with our patients, and obviously patient-centered care comes to the solution and to the rescue. While expansion to access and functionality of our health institutions is necessary, the greater need is a result by healthcare providers and teams to be more committed to their duties. We must do this with some reasonable level of integrity, ensuring that the voice of the patient and family is not silenced in the course of our relationship. In consonance with the physician's pledge, and I thank God that we all took that oath again today. In consonance with our physician's pledge, our patients ought to be respected and treated fairly. Saving lives is not just the cure of an ailment, but the total well-being of the patient, who must be a friend and partner in the healthcare process. Even more compelling is the need for a clear strategy and the establishment of patient-centered governance systems, where patient-centered care is the business of everybody in the organization. The structure must be such that encourages the participation of all, while enabling the patient to fully share in the decision-making process. The PCC model is enhanced when roles of team members are clearly spelled out in a way that is empowering and invites accountability. Accountability not in terms of money, but accountability in terms of doing what we ought to do, and the patient and family doing what they ought to do. A partnership that can be trusted, a partnership that breeds confidence. Finally, the following statement by the late American civil rights activist, Maya Angelou, in my considered view, speaks to the very heart of patient-centered care. And in quote, "I have learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. The Nigerian patient, if you treat him well, if you create a partnership that is enduring, will not forget the good that you have done. But when we treat them as if they are just a burden to us or a burden to the nation, even the very poor amongst them will start to look for funds to go overseas, or they may have to look for alternate ways of treating themselves, which will not be in their best interest. It is on this note that I wish you fruitful deliberations at this summit and look forward to receiving your recommendations in the days and weeks ahead. And I hope that the recommendations that come out of this place will be communicated to the Ministry of Health and from the Federal Ministry of Health to every state government and to every local government, because we now require a true partnership between the leaders in governments and the leaders in the healthcare system. And it's important that this partnership will work. And all of us must realize that collaboratively, we must work with our patients and Nigerian people to ensure that the best of care is provided for them. God bless you.
Economy, security, politics, sports, and more. Stream live on your smartphone and tablets and stay connected. It's pretty easy. Simply download NTA News app from your Google Play Store and you're good to go.